We're very lucky to have Dr. Ellen Elias here. She's a full professor of pediatrics and genetics with tenure at the University of Colorado School of Medicine. She directs the Special Care Clinic at Children's Hospital Colorado, the largest clinic of its kind in the U.S., where children with medical complexity receive both primary care as well as coordinated consultative care for their genetic, medical, and developmental disorders. She was one of the original geneticists to discover the cause of the disorder, Smith-Lemli-Opitz syndrome, and continues to pursue clinical research regarding the care and management of patients with this disorder. Ladies and gentlemen, here to talk about the principal sterol of all higher animals, cholesterol, it's Dr. Ellen Elias.
Hi, good morning to you. I'm so thrilled to be here. Mira Irons and I were partners in crime in Boston here, and it was in our patients that the problem with cholesterol was first identified. So to just elaborate just for a second on that wonderful talk from Dr. Porter, in 1964, Dr. Smith-Lemli-Opitz first described 3 little boys with what we now know as Smith-Lemli-Opitz syndrome. And it was actually 30 full years later, in the early 1990s, that the cholesterol metabolic error was first identified in patients with SLO. And these were children that were followed by Dr. Mira Irons and I. They were quite severely impacted with their disease and had very, very low cholesterol levels. It was not subtle at all, very severe feeding problems, and needed to be fed with feeding gastrostomy tubes. So what we were seeing at first and identifying were patients with what I think about in my mind as classic Smith-Lemli-Opitz syndrome. And as Dr. Porter so eloquently described, the problem with Smith-Lemli-Opitz is that you cannot go in the very, very last step of this very complicated pathway to make cholesterol in your body. You cannot get rid of this extra double bond and make cholesterol. And 7-dehydrocholesterol is what we call the precursor that builds up in your body. You cannot make this conversion step. And 7-dehydrocholesterol gets converted back and forth to a very, very similar compound called 8-dehydrocholesterol, where the double bond just flips up one space right up to here. So when you have Smith-Lemli-Opitz, you can actually identify these much higher than normal levels in your body of both 7 and 8-dehydrocholesterol. And generally, if this step is missing enough, defective enough, you can end up with pretty low cholesterol levels. So we have learned so much about this cholesterol pathway in the last 30 plus years since this discovery was made. So SLOS was the very first disorder in this pathway that was identified in people, the very, very first. And ever since then, with work done by many, many people across the world, there are now many, many other disorders that have been identified in this pathway too. SLOS is the most common of all of these disorders. These other disorders are quite rare. And these conditions share some common features with SLO, but these children tend to look different because the features that you see are not just because your cholesterol level may be low, but you're also building up different precursors in these other very, very rare disorders, which makes you look different. So what does it mean? Why do we care? What happens if your cholesterol level is too low? Well, we've learned a whole lot about that too. Back in the day, everybody just thought that cholesterol was bad. If you had too much of it, you had to take a medicine, a statin, to try to get rid of it, and you developed heart disease and early heart attacks and things like that because cholesterol was bad. And we now know, in fact, that cholesterol is something that everybody's body needs for many, many, many different things. So we've identified that, in fact, to make your organs form correctly, cholesterol is very, very important for this pathway of special genes that tells the fetus very early on how to form the brain, the heart, the kidneys, the limbs, the genitalia. So you need cholesterol to activate that pathway and end up with organs that look normal. And so if the fetus is very, very deficient in cholesterol, this pathway cannot function properly, and you can end up with these multiple birth defects. We also know that cholesterol is extremely important in the outside of your cells, the cell membranes. The amount of cholesterol that's in the membranes around every cell in your body and every organ system is critical for those cells to be able to function properly. And so if the cholesterol level is really low, then you're going to see problems in multiple parts of your body, particularly in those areas where your body is making new cells all the time. Cholesterol is what your body uses to make hormones, certain hormones that are important, especially something called cortisol made in your adrenal glands. It's really, you need cholesterol to make those important hormones. From cholesterol, your body makes bile acids, which are in your intestines, and you need bile acids to absorb certain nutrients in your gut. So people with very low cholesterol levels can have really low bile acids, not be able to absorb nutrients, and can end up with nutritional significant issues. So your liver is where cholesterol is made predominantly in your body. And so your liver is working super hard to make cholesterol, but can't quite do it. And people with severe disease can end up having quite significant liver disease and actually die related to liver disease in early infancy in patients with very severe disease. And we know also that cholesterol is really necessary to help your body fight infections for several different reasons. Your white blood cells, for example, don't work very well. Their membranes don't work very well to help fight infections. So what happens when the liver, which is trying to make cholesterol, but has this enzyme deficiency, and instead is making lots of these precursors, the 7 and 8 dehydrocholesterol, what happens? So we know that there are all those problems when you don't have enough cholesterol to do all those things I just mentioned. But one of the things we've also learned is that it's a problem when those precursor levels build up to higher levels than they typically should be in your body. So one of the things that we've learned and identified is that you cannot just substitute the precursors, the 7 and the 8 dehydrocholesterol. You cannot just exchange them with cholesterol. They just don't work, okay? They don't do the same things that cholesterol does. And what we also know is that these increased levels play a role in certain symptoms and problems that people have. For example, the higher the level of 7-DHC in your skin, the worse this photosensitivity, this increased sunburning that many patients have is in part related to this increased level of the precursors. And we know now by the work of Lieb and Zhu, predominantly, that the precursors, the 7 and the 8 dehydrocholesterol, go through this chemical reaction called being oxidized, and that makes them turn into toxic substances that are called oxysterols. So the level of many, many different forms of oxysterols build up in your body when you have Smith-Lemli-Opitz, and they can cause really significant damage and toxicity to different places in your body. And a lot of science and research has been devoted to what happens when these very toxic oxysterol compounds are present and build up in the back of your eye, the retina, and in your brain, and can cause significant damage there. So in our original patients here in Boston, the town where this all started, we wanted to do something to raise their cholesterol, and we all knew that what you eat can certainly raise your cholesterol if you eat high cholesterol foods. So we thought, well, why can't we just give people cholesterol? Well, that was kind of tricky and hard. First of all, our patients had the significant feeding issues that Dr. Porter described, so they were not able to eat a typical diet. They couldn't chow down on scrambled eggs for breakfast and steak for dinner because they were mostly being fed through feeding gastrostomy tubes. And the pediatric formulas that were available at the time back in the 90s, and it's really still the case now, all these years later, pediatric formulas had very low levels of cholesterol in them. It turns out that for babies, breast milk is actually a better source of cholesterol than most pediatric infant formulas because you just can't get enough cholesterol from those formulas. And also what we noticed is that many of our patients were unable to tolerate certain foods. They actually were allergic, and their intestinal tract was just very sensitive to certain foods. They didn't tolerate them very well. So we couldn't just add eggs to their diet very well. So what did we do? We invented a cholesterol medicine. So that was kind of tricky because most people don't want to give cholesterol. They want to take it away. It happened that I was lucky. My cousin was a senior executive. He's a biochemist, and he was a senior executive in a pharma company called Spectrum Janssen Pharmaceuticals. And he said, we're having Thanksgiving dinner together. And he said, well, my company makes pure pharmaceutical grade cholesterol. And I said, you're kidding. Oh, wow. So we worked with a pharmacist in Boston and tried to figure out what could we put cholesterol in to turn it into a medicine. And there were some studies. We can put it in lots of different things, lots of different kinds of oil. And there were some studies that were done in animals that showed that if you put cholesterol in oil, it was taken in by the body a little bit more easily. So we decided to put it into soy oil. And if the child happens to be allergic to soy, which sometimes happens, we can put it in other things like grapeseed oil or other kinds of oils that the child can tolerate. But we developed a very concentrated medicine of cholesterol. It's the equivalent of 5 eggs per teaspoon. And so I could get a lot of cholesterol in a very small volume into my patients with Smith-Lemli-Opitz. So at first, I had to go through the Food and Drug Administration and get permission to give this brand new medicine to my patients. And so we were granted what's called an IND number, an investigational new drug number from the SDA for me to be able to give cholesterol to my patients with SLOS. And then over time, because it's been so incredibly safe to use this and really virtually no side effects, and as Dr. Porter mentioned, giving cholesterol to a patient who has very little cholesterol is now considered standard of care. I don't have to use an IND number anymore. I can just prescribe it. There are there are pharmacies all across the country that know how to make this suspension. And it used to be, when I lived here and practiced in Boston for 17 years, there was a shipping pharmacy that would make it for me and ship it out all over the country to my patients. And then 24 years ago, I moved to Colorado, and I had a pharmacy there that can make it for my Colorado patients, and now there are stricter rules about insurance paying for this, so I have to find a pharmacy locally for my patients wherever they live and send them the recipe for how to make it, and that's how I'm dispensing it now to my patients. So I have had many, many patients now who've been using this soy-based cholesterol, very concentrated suspension. We followed very carefully blood and kidney and liver tests for the patients over all of this time without any bad side effects. And so I've been able to raise cholesterol levels. I've been able to see some improved growth in these patients, because if your cholesterol level is higher, you can make more bile acids in your gut, absorb nutrients better, and I can get a much higher dose into my patients than just by using eggs alone. Now, I do now have some milder patients who are able to eat higher cholesterol foods, and I can work with one of the 5 dietitians I have in my special care clinic and provide a high cholesterol diet recommendations to my patients who are able to eat. Sometimes I still give patients a little bit of the cholesterol suspension on top of that just to try to get their levels up. There was an aqueous suspension, so it's this cholesterol preparation that's made with a water base instead of an oil base that was invented down in Baltimore, and there are many patients around the country who use this suspension as well. Mine is 250 milligrams per ml. This aqueous-based is 150 milligrams per ml, but it's quite concentrated, and a typical egg yolk has 200 milligrams of cholesterol in it. The prescriptions for both of these are available. You can buy these pharmaceutical grade powder and make it up as a suspension. A pharmacist can do this. It lasts a long time. It's very stable, the oil-based one is. And there are recipes and instructions that can be available to your local pharmacy to make this. There are other forms of cholesterol that have been identified very often by patients of mine who are really, really smart at figuring these things out. So a lot of people are able to use high cholesterol foods with eggs, red meat, some dairy. Some people love liver. Chopped liver is yummy. And then the aqueous suspension is used in some patients. I had moms who were super creative and made, I found options on the internet. And remember, the egg whites don't have the cholesterol, it's the yolk, okay? Special milkshakes were invented by some of my moms using eggs and heavy cream and flavoring. In Boston, we invented this log formula I'll show you in a minute, and then this Cholesterol product has been available online. There's a recipe for the log formula, and my understanding is people will have access to the slides. One of my moms used this in her child, God bless her, because I don't know how she did it, but it looks disgusting, it smells disgusting, but you start with baby food meat, and then you add oil to it, and sugar, and calcium, some vitamins, and some saline, and looks awful, smells awful, but it works quite nicely to get your cholesterol level up. And then here are a number of products that one can find online where you can just buy cholesterol as a powder or as a capsule and get cholesterol into your child that way. I wanted to make one quick comment about newborns. So very, very sick newborns and young infants may be critically ill, may be in the neonatal intensive care unit, and because they're so sick and so fragile, they're actually not being fed and they're not eating. And so all of these different products you can't really use and put into their gut very well. There's no way to give cholesterol itself, pure cholesterol, as an IV medication to patients. So there's a blood product called fresh frozen plasma, or FFP for short, and that can be given to a critically ill newborn to try to get the cholesterol level up. It has, we give it 10 milligrams per kilogram, and it can raise cholesterol in a critically ill newborn who's not able to tolerate feeds. We can give the cholesterol suspension either through a nasogastric tube, through the nose down into the stomach, or if the baby's a little bit older and gets a gastrostomy tube placed, we can definitely do it that way. Cholic acid is a form of bile acid that can be used in severely affected newborns to raise the ability to absorb the cholesterol that they're able to get in their diet. Cholic acid in and of itself is not going to raise your cholesterol, but can help you absorb cholesterol that you're giving. The study that Dr. Rizzo and I did to give cholic acid, we didn't give it to anybody younger than the age of 2, just because we were trying to safely have kids travel to be able to be on this protocol, and we were worried that very critically ill young infants were not going to be stable enough. So there has not been a study in young infants to use cholic acid, but I would love to see that done, because that's a population that I think might benefit from this. Cholextra is one of the original powders that first became available. It's tasteless, it's easy to dose. You can carry this powder around with you, and a level scoop. One scoop has a little over 330 milligrams of cholesterol in it. That's been a product that many of my patients have tried. So how much cholesterol do you need? Well, if your level is 10, you obviously need a lot more than if your level is over 100. I'm trying to get the cholesterol levels to be over 125, but sometimes the child has such severe disease, I can only get it up to 50, no more. So I've been using a higher dose of cholesterol, somewhere between 100 to 300 milligrams per kilogram of body weight per day. That's divided into 3 times a day of doses, and the more severe the disease, the higher the dose I've used. So one of the things that we've noticed is that cholesterol levels can drop significantly with a severe intercurrent illness, like you get influenza, your level can drop, and with stress, if the child is having a big surgical intervention, levels can drop. So if your cholesterol is super, super low, then you cannot go through the normal stress response that your body generally does with a severe illness and sepsis or with a surgical procedure. So a patient might not be able to make enough cortisol in their body to get them through stress. So generally with a really severe patient, I will give them stress steroids as well and work with the endocrinologist to figure that out. And some of my patients who are very severe and have adrenal insufficiency are on daily doses of steroids. And then I've been using cholic acid in patients with very, very low cholesterol levels to try to help get their cholesterol levels up so that cholesterol is available for all those reactions you need it for. So how often should you check cholesterol levels? I don't just put kids on the medication and then never see them again. I try to really follow and tweak the dose and make sure that everything is okay. I personally use the lab at Kennedy Krieger, and as Dr. Porter emphasized, you cannot just send cholesterol to your local lab, because your local lab and your local hospital cannot tell the difference between cholesterol and the precursors. So in the very beginning, if I have a critically ill baby, I'll check fairly often and just until I get the dose right, and then every 3 to 6 months. And for the patients who I follow who live very far away from Colorado, I'll work with their local physicians to get levels drawn. I wanted to say a special thank you. I am so fortunate in my clinic, special care clinic. I have incredible resources. We follow over 5,000 very complicated children with many different genetic diagnoses, and I have now 2 embedded pharmacists who help me with special medications, including the cholesterol and the cholic acid. And Dr. Orth helped provide some information for these slides to share with you today. And I especially wanted to thank all of my families, my patients and their families who just taught me so much over the last 30 plus years. I still remember the phone call from the very first patient we reported, whose picture was in the New England Journal of Medicine. And the mom called me up and said, "Dr. Elias, Sarah's in the swimming pool." And I said, "Oh, that's nice." And she said, "You don't get it, do ya?" Sarah's never been able to go outside before because her photosensitivity was so severe. But when we started her on some cholesterol, that improved, and she was able to go outside and be in the family swimming pool for the very first time in her life. I didn't know about the photosensitivity until that mom told me about it. And it was the same mom who told me a few years later, called me, "Dr. Elias, Sarah is blind. She can't see in the dark." She was crawling right in, they turned the lights off so she could see the lights on their Christmas tree, and she clearly was blind in the dark. And that was the first time that I realized that there was a problem with vision and with the retina. And then I started to look at all of my patients and assess their retinal function and try to prevent that progressive retinal disease from happening in other patients of mine. So these patients have taught me so many things about this disease that we never knew and never appreciated until very astute parents figured out these changes and let us know. So I want to thank you to all of my patients for what they have taught me. Thank you very much. I have a whole lot of references for people in the end, and hopefully you'll have access to these slides if there's anybody who wants to look these up in more detail, and I'd be happy to answer any questions.
We have time for a question before our break.
I've got a question. I'm from North Carolina. How can we get what you do in North Carolina?
That's a great question. So I do see patients that come from all over the U.S., and I only need to see them once a year. So if it's possible for patients to travel to Colorado once a year, I can enroll them and see them in my protocol, which is looking specifically at the role of using antioxidants to prevent these toxic oxysterols from accumulating. And I do very special eye tests and hearing tests to see the effects of that. So, but I do also work with people who are too fragile to travel. And I can work with your local physicians in your local geneticist, your local GI doctor, your local specialist that your child is seeing to try to figure out a way. The cholesterol medicine is considered standard of care, so you don't need to see me to start on that. And the recipes for making the different kinds of suspensions are available online. And then there are high cholesterol foods that are well known and easy if you can work with a nutrition to do that.